All right, part 5 of the 12-lead ECG review. We're going to do a quick review of bundle branch blocks and Wolff-Parkinson White. Again, this isn't a complete lecture. This is just to help you study and to bring out the high points of both of these topics. So our objectives: identify left bundle branch block on the ECG. We're going to talk about the identifying factors of the left bundle branch block. Identify the right bundle branch block on the ECG, and of course the identifying factors and what leads to look in. And also, we're going to discuss preexcitation, the concept of preexcitation and aberrant pathways, so that we can identify Wolff-Parkinson-White waveform on the ECG. So to start with, bundle branch blocks. A bundle branch block is a block of the right or left bundle branches that propagate depolarizations from the sinoatrial node to and through the ventricles. The signal is conducted first through the healthy branch, then the signal is distributed to the damaged side. The skewing of one ventricle takes longer than the other, so it widens the QRS complex. So that's why you see changes in the QRS complex, because normally when you have a normal ECG, both ventricles, both bundle branches, are depolarizing at the same time. So essentially, both of those complexes are superimposed on top of each other in the normal ECG, so you don't see anything other than just one waveform. But in this case, you've got a slow block on the left or the right bundle branch, and so one side gets depolarized, and then a wave of depolarization goes from that side to the other side, which then will cause that the block side to depolarize. So bundle branch blocks only can be diagnosed with a 12-lead tracing. We've got to look in V1 and V2, but especially V1. That's where you're going to see your key identifying factors. Now we can also use lead 1 and V6 to help us determine some changes in like the S wave or the R wave to give us a clue. One of the things you need to remember is that the QRS complex is going to be wide, is going to be greater than 0.12, and it's also going to be a sinus rhythm typically. So you'll have a P wave, but then you will have a greater than 0.12 second QRS complex. So when the left bundle branch block occurs, the left ventricle cannot be depolarized normally. Electrical impulse transmitted from the right ventricle through interventricular septum into the left ventricle indicates significant and widespread myocardial disease. So one thing that Dr. Sen, our current medical director for Southern Union, has told me in the past is if we see left bundle branch block associated with chest pain, we're going to treat it as it is MI. So we'll treat it just like we would a STEMI, because this is very well showing us that you've got myocardial disease going on. If the QRS looks like a W in V1 and an M in V6, it's a left bundle branch block. This is called the William method. And if the QRS looks like an M in V1 and a W in V6, this is a right bundle branch block, or the Morrow method. So this is what we're talking about here. I see a W here, so I've got a deep wave there in a W. Now it's not always going to look perfect, but this is in V1, and then an M with my waveform here in V6. Likewise, I've got an M here, which is going to be a R prime wave in V1, and then a W in V6. So here's an example here. So in V1, you've got the W, and here you've got the M, which is small, but you've got the M there. On the flip side, with the right bundle branch, you've got your R prime wave here in V1, and then you've got the W here with a slurred S wave or terminal S wave in V6. So here's an example here. So the first thing that you'll notice is that the QRS is wide and bizarre. So if we were to look at this real closely, we'd see we've got a wide QRS in our other leads. Next thing I'm going to do is look at lead 1. So I notice that I've got this terminal S wave, or this slurred S wave. V6, the same thing. And now I'm going to go to V1. And I'll notice here that I've got an R prime wave. So I've got the M shape here. Okay, so this indicates two different QRS complexes, or an RSR wave. So that's going to be a right bundle branch block. So again, your terminal S waves, also an AVL as well. With a left bundle branch block, so what you see is going to be a wide QRS, but then you see your terminal R waves. So they're ugly. Just round it up here. But then I've got this deep S wave here that does the W. So I've got a terminal S wave in V1. I've got my terminal R waves in leads 1, AVL, and V6, and naturally we've got the wide QRS, so this would be a left bundle branch block. Alright, so now we're going to move on to preexcitation. So preexcitation is a condition in which you have an aberrant pathway, so a pathway that does not go through the AV node. You can have a left-sided or right-sided accessory pathway, but the preexcitation comes in when we're talking about preexcitation of the ventricles. So instead of having the moment of delay at the AV node, the conduction takes this accessory pathway into the ventricle from the atria, and it immediately depolarizes the ventricles. So this will be a couple of things that you would see. One of the things you're going to see is a shortened PR interval, because you don't have the period of time where the AV node is holding off. And you're also going to see the presence of a delta wave, which essentially just shows the conduction going straight into the ventricle. So where normally you would have your P wave and then you would have your moment there where you have your PRI, with the accessory pathway or preexcitation, you're going to have a very short PR, and it's going to go straight into the ventricle. Really should look more like this. So there's two different types. The main one we're going to talk about right now is WPW, or Wolff-Parkinson-White. Wolff-Parkinson-White syndrome refers to the presence of a congenital accessory pathway and episodes of tachyarrhythmias. So somebody with a preexcitation condition, such as Wolff-Parkinson-White or Lown-Gangong-Levine syndrome, LGL, are predisposed to certain tachyarrhythmias, SVTs, even atrial fibrillations, and atrial flutters as well. So your accessory pathways, you actually can have a left-sided or right-sided accessory pathway, and on the ECG you will see the characteristics of Wolff-Parkinson-White, so the short PR interval and the delta wave, but then you'll see some other changes depending on what type it is. So again, the accessory pathway, so this example right here is showing a right-sided accessory pathway, but you could have a left-sided accessory pathway as well, and because of the way that it's depolarizing, that it will show up a little bit different. So left-sided accessory pathway, also known as a type A Wolff-Parkinson-White pattern, you see a delta wave in all precordial leads and a RT discordance, or you've got an upright R wave and a inverted T wave in V1. For the right-sided, you'll see a negative delta wave, often in V1 and V2, and a dominant S wave in V1. So here's an example of the delta wave here. So this part right here would be your normal PRI, but because we've got an early depolarization by an accessory pathway, we're going to go straight into ventricular depolarization. So a delta wave is a slurring, slow rise of the initial portion of the QRS. You're going to have QRS prolongation and discordant ST segment and T wave changes. So here's an example of a Wolff-Parkinson-White type A ECG. Now your ECG monitor, if it distinguishes this, it should be able to tell you if it's a type A or type B. Treatment is going to be essentially the same. Now we will not give adenosine for Wolff-Parkinson-White. We would consider procainamide, or procainamide would be the drug to give in this case. Adenosine would not work for Wolff-Parkinson-White because adenosine slows the conduction at the AV node. And so this is not an AV nodal issue when they go into a tachyarrhythmia. So with the left side, the dominant R wave in V1, so remember from earlier review, we talked about the R wave progression in your precordial leads, but in this case you don't have an R wave progression, you actually have a dominant R wave, but you've got a delta wave right there. So note your delta wave. So when you see this in tall R waves and inverted T waves, or an RT discordance in V1 through 3, this is due to Wolff-Parkinson-White. Now also notice here in AVL, you've got a negative delta wave. Now you got to look really closely, but you'll see right in here is where the negative delta wave is. A type B, or right-sided accessory pathway, you're going to see inverted delta waves in V1 and V2. So it kind of looks like a bundle branch block, but you don't have the R wave slurring or the terminal R waves in 1 and AVL in V6. But if you notice here, you've got this delta wave in V1. Regardless, you're going to see delta waves shorten PR intervals, and you should know that Wolff-Parkinson-White is due to an accessory pathway, and these patients are going to be predisposed to tachyarrhythmias. So that concludes the review for Part 5. We talked about bundle branch blocks, and we talked about Wolff-Parkinson-White.